Okay, thank you, Dr. Gleave. Welcome everyone to this morning's Grand Rounds. I've chosen the topic Klinefelter syndrome and fertility implications. As Dr. Gleave mentioned, I'm PGY2 here at UBC, and we can get started. So just some of the learning objectives that were circulated prior to today's presentation. I hope at the end of this presentation that we'd be reviewing clinical features and pathophysiology of Klinefelter syndrome. We also would hope to provide an overview of current knowledge of Klinefelter syndrome implications on fertility, and then finally to discuss fertility technologies and interventions that could be used to improve or preserve fertility in these individuals. So I hope to kick off today's talk by briefly going through the history of Klinefelter syndrome. Klinefelter syndrome was originally described in 1942 in a paper by Dr. Klinefelter himself. It describes a series of 9 patients, including 7 seen at the Massachusetts General Hospital and 2 additional private patients. These individuals were found to have what they called aspermatogenesis, hard, small testicles, gynecomastia, increased FSH secretion, and normal to reduced function of Leydig cells. This paper was followed 17 years later in 1959 by Jacobs and Strong in a single case report published in Nature. It was titled "A Case of Human Intersexuality Having a Possible XXY Sex-Determining Mechanism." This paper followed a 24-year-old patient exhibiting many of the previously mentioned features of gonadal dysgenesis, gynecomastia, and small testes, in addition to poor facial hair growth and high-pitched voice. Ultimately, it was this case report that linked this syndrome to a karyotype suggestive of 47XXY, using just standard karyotyping at that time. And so, by definition, Klinefelter's disease is defined as having a supernumerary X chromosome, or at least 2 chromosomes, in addition to a Y chromosome. The classic genotype is 47XXY. However, there are also variants which have been seen and documented with individuals having a chromosome complement of 48 XXXY, 48 XXY, as well as some mosaic individuals as well, which we'll talk about later. Technically, these are all Klinefelter syndrome by definition. And interestingly, there have been several important papers which have examined patients across these various genotypes and their effects on the genotypes based on their, the genotype's effects on the phenotype. One such article is the one that I've included here by Otteson et al. The study looked at stature involving patients not only with the various Klinefelter aneuploidy genotypes, but also included 45X or Turner syndrome patients as well. So one of the inspirations for the study is the SHOX gene, SHOX gene, or the short stature homeobox gene found on both X and Y chromosomes in the pseudoautosomal region 1. As a result, the hypothesis in these patients was that with supernumerary X chromosomes, such as in Klinefelter syndrome patients, this would be associated with their tendency to have tall stature, as opposed to the shorter stature normally or frequently seen in Turner syndrome. So the SHOX gene is known to escape X chromosome inactivation given its location on the sex chromosomes in this PAR1 region. And it was found that height increased with an increasing number of X or Y chromosomes in a nonlinear fashion, up to a limit of 5 sex chromosomes in men and 4 X chromosomes or 4 sex chromosomes in women. So the incidence of Klinefelter syndrome is estimated to be 1 in 500 to 1 in 1,000 live-born boys, so an incidence of 0.1 to 0.2% in the population. It is the most common sex chromosomal aneuploidy, and it's also the most common chromosomal abnormality linked to male factor infertility. In evaluation and workup of infertile males, Klinefelter syndrome is implicated in 3 to 4% of these individuals, and then 8 to 12% of azospermic patients further along in their workup. As a result, most of these Klinefelter syndrome patients go undetected until adulthood, when they present actually initially for infertility. And so I think overall, there's a significant number of these patients that are believed to go through life undiagnosed or misdiagnosed, with some estimates up to about 64% of these individuals. And we're looking at likely underestimation of the true incidence of Klinefelter syndrome. The vast majority of Klinefelter syndrome patients exhibit this classic phenotype of 47XXY. Sorry here, give me 1 second. Okay, so yes, the vast majority of Klinefelter syndrome patients exhibit this classic phenotype of 47XXY, and the remaining 10 to 20% make up the remaining genotypes, which are relatively rarely seen, including the 48XXXY, 48XXY that we had spoken about earlier, as well as some mosaic individuals exhibiting 47XXY in some tissues and a normal 46XY in other tissues. As expected, the mosaic forms of Klinefelter syndrome actually exhibit less severe forms of the features that we've seen in the classic non-mosaic 47XXY. Perhaps not surprisingly, there is an association with advanced maternal age. There's up to a 4-fold higher incidence in offspring of women who were 40 years or older at the time of conception, when compared to mothers who had conceived when younger than 24. As with other syndromes associated with aneuploidy, this is believed to be due to greater rates of non-disjunction during gametogenesis. It is important to note, however, that several studies have found approximately equal distribution, actually, of paternal versus maternal contribution to the development of Klinefelter syndrome and the extra X chromosome. However, due to the stages of meiosis and chromosome separation events involved in meiosis between maternal and paternal gametogenesis, it's only possible for fathers to contribute the extra X chromosome as a result of non-disjunction at the stage of anaphase 1, as opposed to both meiosis 1 and meiosis 2 in gametogenesis in mothers. Furthermore, it's estimated that 60% of Klinefelter syndrome individuals have compensated hypogonadism as a result of elevated gonadotropins. However, 25% of patients still demonstrate testosterone below normal levels, and often will undergo testosterone supplementation under the supervision of an endocrinologist, usually at the time of puberty. And finally, just a quick couple points about the incidence of azospermia. Male factor infertility is implicated in or affects 7 to 12% of men. And then in the population that presents for, in our patients who present for workup of infertility, we found that approximately 1% of all men experience azospermia. So I think we've kind of talked about some of the features of Klinefelter syndrome, but some of the classic symptoms that we would see in these individuals are tall stature, gynecomastia, gynoid hips, body hair sparsity, firm atrophic testes, and so on, and infertility clearly as the topic of today's discussion. Overall, the individual features can be looked at as nonspecific, likely contributing to the estimated rate of underdiagnosis. People don't get it checked up on just because these symptoms in isolation don't really raise many red flags to a lot of people. And important for today's discussion will be the infertility, firm hypertrophic testes, firm hypertrophic testes, and hypergonadotropic hypogonadism. So this is another diagram from the European Academy of Andrology guidelines on Klinefelter syndrome. This is published in 2021. This was the only association level guideline that I can find on the management of Klinefelter syndrome, incorporating multidisciplinary care. It outlines presenting signs and symptoms across various life stages. And as you can appreciate, the health implications of Klinefelter syndrome extend beyond fertility and cosmetic appearances. It's important to note that there are psychosocial implications, which manifest early in the form of speech, learning, behavioral, and social difficulties. Also important are metabolic, cardiovascular, and malignancy implications, which are all important to remember when assessing and managing a patient with known Klinefelter syndrome in the adult setting. For example, studies have shown that there's up to a 10-fold increase in the risk of developing breast cancer in 47XXY patients compared to their 46XY biologically male counterparts. And so here's just a quick review of the HPG Access. The hypothalamus will secrete GnRH. This is carried by the hypophyseal portal circulation to the anterior hypophysis or the anterior pituitary gland. There's the under the stimulation of GnRH, FSH and LH are produced. They then travel via systemic circulation to the testes, where they act on Sertoli and Leydig cells. Leydig cells stimulated by LH are responsible for testosterone secretion ultimately, which is in turn essential for proper spermatogenesis. Sertoli cells and Sertoli cell functioning are also critical for spermatogenesis, stimulated by FSH. Derangements in both of these cell types, as you will see, are critical to the pathogenesis of Klinefelter syndrome. The red arrows here, this is a Klinefelter syndrome specific diagram, if you will. The red arrows here indicate expected derangements in Klinefelter syndrome, and the dashed lines here indicate the usual typical negative feedback loops. So going forward with the etiology, as mentioned previously, Klinefelter syndrome is almost exclusively due to non-disjunction of paternal or maternal sex chromosomes during gametogenesis. However, there's a small subset of Klinefelter syndrome attributable to early division of a fertilized oocyte and spontaneous non-disjunction in the early zygote. And as a result, it's here that we see the development of the mosaic genotype for Klinefelter syndrome. So many studies have looked into the genetic etiologies of Klinefelter syndrome beyond simply the supernumerary X chromosome. We've already kind of talked about the SHOX gene and its non-linear.
There's potential that there's two cases.
As mentioned above, we talked about the Ottoson paper there. There's also links to CAG repeats of the androgen receptor gene and its manifestation in the phenotypes that we see in our patients, as well as variability in X chromosome inactivation, which we'll talk a little bit about. So looking at CAG repeats, so those exist on the N-terminal region of the androgen receptor gene. It's highly polymorphic between individuals. And the repeat length is inversely proportional to the receptor activity. So longer repeats lead to decreased receptor activity. And currently the evidence is non-conclusive as to the phenotypic features, as well as whether the CAG repeats are correlated specifically with the origin of the supernumerary X chromosome. But the CAG repeat length is correlated with the severity of the phenotype that we see in our patients. So Going on to ZIST. So ZIST is the X inactivation region of the X chromosome. And so it's a short, it kind of codes for a short 17 kilobase pair RNA sequence. And as you can see in the diagram here, the ZIST gene itself is usually methylated in the active X chromosome. This diagram is from a paper back in 2009, and the thought was that there's another binding protein which designates which is the active and which is the inactive X chromosome, and directs the methylation of the X inactivation sequence. And so, as a result of the methylation, the mRNA transcript cannot bind to the active X chromosome. However, with transcription of this X inactivation sequence, it allows binding onto the inactive X chromosome designated for inactivation, and as a result, silences those genes. However, there's still about 15% of the X chromosome that escapes X chromosome inactivation by ZIST, and this is thought to contribute to the Klinefelter syndrome phenotype just based on dose alone, and shocks in the PAR1 region is an example of one of these regions that escapes X inactivation. So then going into spermatogenesis, just a quick overview again of the development of sperm. There's sperm kind of migrate intraluminally towards the center of the seminiferous tubules, and you can kind of see that on the distribution on histology. They largely start off as spermatogonia, which undergo mitotic divisions to develop primary spermatocytes. At that point, secondary spermatocytes and spermatids are created through meiosis, and ultimately through maturation of sperm with the appropriate stimulation by Sertoli cells, you end up with mature spermatozoa. And so in Klinefelter syndrome specifically, Klinefelter syndrome individuals have fewer spermatogonia than controls. There's some evidence of decreased spermatogonia in childhood, starting as early as the peripubertal, prepubertal stage. And then there seems to be a sharp decline in spermatogonia present at the initiation of puberty going on to adulthood. The decreased spermatogenesis and the fewer number of spermatogonia is thought to be multifactorial, involving Sertoli cells functioning in a deranged fashion, thought to be secondary to their chromosomal makeup, and this ultimately causing an altered, unfavorable testicular microenvironment, as well as possibly due to decreased circulating androgens, all feeding back to that feedback loop in the HPG axis that we were talking about previously, that is deranged in individuals with Klinefelter syndrome. So this here is a study by Diebel et al. It was a systematic review and meta-analysis done in 2020. And it was looking at the age-related presence of spermatogonia in Klinefelter syndrome patients. It involved 36 different articles with a total of 386 patients. And here they found that all subjects had spermatogonia present in the fetal and infantile stage. However, this steeply dropped off around the time of puberty, as you can see between the prepubertal and the peripubertal presence of spermatogonia listed here. This is another paper by Wickstrom, looking furthermore at the accelerated germ cell depletion at the time of puberty. This followed a case, a cohort of 14 non-mosaic 47 XXY boys aged between 10 and 14 years old, so capturing both prepubertal and peripubertal timeframes. They measured puberty progression by testicular volume and had every 4 months undergoing Tanner staging at that point to see when they've kind of progressed into puberty. These individuals underwent a single testicular biopsy. And then the older boys with the larger testes, thought to be having initiated puberty, showed no germ cells on their testicular biopsy. They've also showed Sertoli cell degeneration and Leydig cell hyperplasia, whereas the younger prepubertal boys had adult-type spermatogonia and normal Sertoli and Leydig cells, which indicates that there's changes around the time of puberty that are rapidly progressing as a result of stimulation to the testes. So speaking quickly about androgen deficiencies, the majority of Klinefelter syndrome children enter puberty. However, 62% of the boys can maintain testosterone levels greater than 10 nanomoles per liter. This is thought to be due to hypergonadotropic compensation, but we're still looking at about 38% of boys who unfortunately are unable to maintain this testosterone level. And then androgen deficiency later on in life, like we described in the the European Association of Andrology guidelines. There's several other effects of decreased androgens later in life, such as decreased libido, erectile dysfunction, osteoporosis, in addition to the other conditions that we should be screening for and looking for in our patients here. Because of androgen sensitivity deficiency in infants and boys with Klinefelter syndrome, they can exhibit, albeit less commonly, features of undervirilization such as micropenis, bifid scrotum, cryptorchidism, hypospadias. And so this is why Klinefelter syndrome is part of the differential diagnosis when you have patients presenting with genital abnormalities in the congenital setting. So looking into the microenvironment of the testicle and into the histology, testis pathogenesis is typically linked to progressive hyalinization, fibrosis, Leydig cell hyperplasia, and depletion of germ cells amongst the seminiferous tubules. There's also thought to be progressive apoptosis of 47XXY spermatogonia as patients age. And so looking at this review article by Axcaladi back in 2013, these are histological sections from testicular biopsies from boys and men of various ages. And this is comparing normal testicular histology versus Klinefelter histology on the right. You can see kind of between fetal life and puberty, the testicular architecture seems relatively similar, both kind of in the degree of interstitial cells between the seminiferous tubules, as well as the number and density of the spermatogonia in the tubules themselves. Going on to the childhood age, it seems that there may be a decreased number of germ cells present in the prepubertal Klinefelter boy. During and after puberty is kind of where we see the gross morphologic changes and the widespread degeneration that's typical of Klinefelter syndrome, like we had spoken of before. And so we can see widespread kind of degeneration. You can see, especially in the adult stage, all of that interstitial space is filled up with Leydig cells. There's fibrosis of the seminiferous tubules around, and then gross hyalinization of the tubule as well. And so this is just kind of like a nice look at the changes that we can see on a microscopic level. So going on to the gametic karyotype. So in Klinefelter syndrome individuals, always historically thought to be infertile. It's known to be quite rare to find functional sperm in the ejaculate of these individuals. And as we'll talk a bit about it later, there are reproductive technologies that we can use to extract sperm. Nonetheless, these reproductive technologies are still privy to gametic karyotype derangements potentially found in these individuals. And so there's a 5 to 7% aneuploidy rate in the Klinefelter syndrome sperm compared to approximately 1% in fertile individuals. Possible explanations involve spermatogonia karyotype and the resultant ability to undergo meiosis. And as we'll discuss this last point in a bit more detail, but just a bit of a primer that the data itself is and was inconclusive. So looking at this study from Foresta, this was a study started in 1999, looking at testicular sperm aspiration in 10 Klinefelter syndrome individuals, and they analyzed the sperm and the surrounding cells for their genotype. And so after extracting from 10 individuals, unfortunately, only 2 had germ cells in the specimen for analysis. So we're only really looking at 247XXY patients in this data set here. As you can see in these 2 individuals, the Sertoli cells, spermatogonia, primary spermatocytes, and secondary up until primary spermatocytes were all of the 47XXY genotype. And so the spermatogonia and the primary spermatocytes, especially being progenitors for spermatozoa, showed 100% distribution in their samples for being of the same as the somatic genotype of these individuals. And you can see that going forward in the production of these secondary spermatocytes, spermatids, and spermatozoa, they were able to produce 23X, 23Y gametes. And as a result, the conclusion was that 47XXY non-mosaic spermatogonia are capable of completing meiosis and lead to mature spermatozoa. This was another study done in 2009 by Scuriano et al. They had a similar setup with sperm aspiration, and they underwent FISH or fluorescence in situ hybridization for visualization of the chromosomes here. It involved 11 adult patients with 47XXY genotype, non-mosaic Klinefelter syndrome patients, and only 6 of them had a spermatogenic foci. So those are the ones to go on to further analysis. And on their fluoroscopy, they demonstrated that actually all of the spermatocytes undergoing meiosis were 46XY. And so as a result, their conclusion was that, only those with the 46XY euploid genotype were allowed to progress further on to spermatogenesis. And so possible explanations for this that the authors offered here were that there was either a spontaneous loss of an extra X chromosome somewhere between the primary and secondary spermatocyte phase, or perhaps there was a tendency of 47XXY spermatocytes to undergo apoptosis, and that's why they were only able to find 46XY spermatocytes in their study. Recently, however, in the last 5 years, there have been several papers published which have utilized single-cell RNA sequencing in the context of Klinefelter syndrome. Some of these papers have been looking at gene expression patterns alongside network analysis, and there have been efforts made to further characterize testicular cells according to their expression profiles rather than just morphology and function alone. And so one such paper was this by Dora et al. This was done in 2017. It involved 3 Klinefelter syndrome and 3 control individuals. And so it looked at use RNA sequencing to look at the testicular transcriptome and see how Klinefelter syndrome patients had modulated their transcriptome, leading to focus of hypospermatogenesis. And so in their analysis, they show that, there were 303 upregulated transcripts and 747 downregulated transcripts seen in Klinefelter syndrome individuals compared to healthy controls. And so on the left here, we see an RNA sequence array. Again, this is just kind of a quick look at the green being downregulated genes, the red being upregulated genes. And this was just comparisons between the individuals, as you can see on the x-axis here, comparing Klinefelter syndrome and control individuals individually. The control group was a pooled analysis of the three control individuals that were brought into the study. So there was a pooled RNA thought to be a representative sample. So looking over the gene profiles and the domains resulting from this analysis, the thought was that those that were downregulated in the green were ones that were responsible for cell morphology, morphologic alterations, and those that were upregulated were those that were associated with hypoproliferation and apoptosis, thinking that ultimately that this data supports a spermatogenic impairment is due to functional and morphologic alterations in multiple aspects of testicular function, and that hypoproliferation and apoptosis play a role in testicular pathogenesis and likely infertility. There have been subsequent other studies by other authors demonstrating upregulation of IGF-BP5, as well as several other genes. IGF-BP5 brought up as an example as a gene that's implicated in the development of fibrosis, also seen in the development of pulmonary fibrosis. And this kind of plays into account the fibrosis that we see in the testes of our Klinefelter syndrome patients. So now I'll move on to talking about therapeutics and some of the techniques that we can use to improve fertility and offer fertility to these Klinefelter syndrome patients. Ultimately, the goal is to optimize sperm retrieval efforts. There are medical interventions and surgical interventions that kind of go hand in hand to improving fertility in these individuals. And I'll also briefly talk about future directions and experimental treatments that are currently being investigated. So looking at the hormone replacement therapy, just kind of a broad stroke for individuals with Klinefelter syndrome, not just for focusing on fertility. They recommend that adolescents undergo testosterone supplementation only in cases where there is clinically evident hypergonadotropic hypogonadism, such as in delayed puberty. And then once you're in the adult phase, testosterone replacement therapy should not be started in patients with Klinefelter syndrome when there's the plan to undergo a testicular sperm extraction. Currently, there's limited evidence examining the deleterious effects of testosterone supplementation and the future fertility outcomes and sperm retrieval rates. These kind of studies would require long-term follow-up and longitudinal data. And the EAA states that they can't provide any recommendations around stopping testosterone therapy prior to undergoing testicular sperm extraction. Some of the other options that people are using for hormone replacement therapy, and also around the time of TESI, would be human chorionic gonadotropin, or HCG, selective estrogen receptor modulators, aromatase inhibitors, as well as topical testosterone usages and in specific use cases. Looking at HCG therapy in Klinefelter syndrome, this was a paper with some helpful recommendations from the group out at Wake Forest. Their practice recommendation in providing HCG therapy in Klinefelter syndrome individuals in the scope of infertility was that when there's long-term testosterone replacement therapy expected, to stop testosterone therapy for 1 month at least once a year and replace it with HCG daily for that month. And then if we're counseling a couple that's attempting pregnancy, to stop the testosterone replacement therapy for 6 months in advance and to replace that with HCG therapy. There was this paper that was recently published in late 2020 by Guo et al. And so this group looked at 184 patients with Klinefelter syndrome undergoing microtesty, and also kind of looked at the role of HCG therapy at that time. And they found that HCG treatment in Klinefelter syndrome men did not influence sperm retrieval rates by microtesty, but in part of their analysis also found that elevated testosterone levels does predict their success. So there's a bit of kind of multiple recommendations going forward, and it seems that HCG therapy currently is dictated mostly by expert opinion. Talking about surgical options now, testicular sperm extraction. It was first described in 1996 by Tournay et al. And at that point, they were performing sperm recovery in 947XXY Klinefelter patients. And interestingly, in 1997, the year after, when combining TESI with intracytoplasmic injection, or ICSI, they were able to have patients who were able to get pregnant and have a healthy birth from a father with Klinefelter syndrome, non-mosaic Klinefelter syndrome, using TESI extracted sperm in ICSI. That was published in JAMA. Quick overview of Microtesty. I realized that some of these technologies were also addressed by Anna Black 2 weeks ago. But as the name implies, so microscopic testicular sperm extraction involves the use of a surgical microscope and a trained urologist in that domain. There, an incision is made into the testicle, and what the surgeon at that point is looking for, what the urologist is looking for, are these dilated seminiferous tubules, as opposed to the fibrotic seminiferous tubules that would surround it. And so that's kind of demonstrated in our in this diagram over to the right here, that we're targeting these kind of engorged tubules and using them for a source of sperm. There's been a quoted 40 to 70% sperm retrieval rate by Microtesty. More of the recent studies have quoted around 40s to mid 40s. In the setting of Klinefelter syndrome, the success of Microtesty has been shown to be independent of age, and I'll describe that a little bit later as well. One of the recommendations from that paper from Wake Forest was that Microtesty is preferred for Klinefelter syndrome patients due to less biopsy tissue in the context of their testicular size, less disruption to the testicular architecture, as well as a smaller chance of testicular devitalization. And the sperm that's retrieved from Microtesty can either immediately be used for ICSI after investigation, or they could also be cryopreserved. A quick couple points on ICSI, or intracytoplasmic sperm injection. It's a technique that's used during in vitro fertilization. We have a single sperm that's injected directly into the egg for the purposes of fertilization. ICSI is associated with an increased chance of fertilization, but has been shown to have a reduced rate of implantation in the setting of male factor infertility, such as in Klinefelter syndrome. This is thought to be due to factors surrounding egg or sperm quality overall, which is quite poorly understood. and requires further research. And in Klinefelter syndrome individuals where sperm are already so difficult to come by, it's almost exclusively the option used as opposed to conventional in vitro fertilization. And so just a quick stat on ICSI. When male factor infertility is involved, ICSI use has increased from 76.3% in 1996 to 93.3% in 2012. This is data found from the CDC down in the States. There was this one study, probably the largest study to date, looking at sperm recovery and ICSI outcomes in Klinefelter syndrome patients. It's a systematic review, a meta-analysis published in 2017, looking at a total of 37 trials, over 1,200 patients. And in this study, they found that there was a 44% sperm retrieval rate, 43% pregnancy rate via ICSI, as well as a 43% normal live birth rate. And so this is kind of where those mid-40s kind of success numbers for TESI have been quoted from. They also found that these rates were independent of age, testis volume, hormonal levels, FSH, LH, or testosterone, and as well were the same if the patient were to undergo bilateral versus unilateral TESI. So I also wanted to discuss quickly about the ethics and the timing of sperm retrieval. There have been some thoughts, some theoretical risks posed previously about the risk of testicular damage, the risk of decreased testosterone levels when you're operating too early to retrieve sperm. But however, when waiting a bit too long, the worry at that point becomes progressive decline in the fertility potential. Early data actually showed that the sperm retrieval rate in individuals who are older than 35 years old was 23% as opposed to 71% in younger individuals, which is where I think some of this worry has come from. Here is a kind of treatment algorithm, again, through that Wake Forest group, in patients diagnosed with Klinefelter syndrome. And so one of their first criteria really is whether or not the patient has initiated puberty. If so, they would progress on to Microtesty, ICSI, or also this round sperm injection, which is still kind of in its early phases right now. If this patient is not undergoing or has not undergone puberty, they would kind of look for an opportunity to go in and retrieve sperm without putting this patient under a specific anesthetic just for this. And so these would be for patients who are already undergoing therapy, and that's several fold. One to prevent multiple anesthetics, unnecessary anesthetics for these children, which is shown to be at an increased risk for developing neurocognitive issues, but as well for the preservation of the sperm, of the testicular parenchyma. And then down below, there's some discussions about experimental treatments, such as spermatogonia or spermatic stem cell culture and propagation with autotransplantation or in vitro spermatogenesis. There's this one study here looking at, very recently actually, published in this month, looking at delaying testicular sperm extraction in 47 XXY patients. And they show that this does not actually impair the sperm retrieval rate. And so this was looking at 119 individuals with classic Klinefelter syndrome. They underwent conventional TESI, which are essentially random biopsies of the testicle for sperm extraction. They divided their patients up into two groups, 15 to 22 years old, and then 23 to 43 years old. And they demonstrated that with an overall sperm retrieval rate of 45.4%, there was no significant difference between the young and the adult groups for retrieving their sperm. With regards to future directions, I briefly talked about it already with spermatogonial stem cell development. There's been an interesting move in research over the last 15, 20 years regarding stem cell therapy and in vitro propagation of sperm. For example, one such paper published in 2009, the one in the top right corner by Dr. Sadri Arnikani, demonstrated an 18,000-fold increase over the number of human spermatic stem cells in their experiment with culturing SSCs in vitro. And this all took place over the span of just 64 days. Now, keep in mind that naturally functional mature spermatozoa are rare in Klinefelter syndrome patients. And as such, these patients would not be good candidates for other experimental therapies for fertility, namely autotransplantation, which I believe was covered in Anna's talk on fertility and oncology 2 weeks ago. However, with the advent of spermatogonial stem cell culturing, autotransplantation may be a possible avenue for Klinefelter syndrome patients in the future. This would allow for in vitro differentiation of mature spermatozoa as well. And this is also currently in the early experimental phase. As well, with the advent of non-invasive prenatal testing and it becoming more readily available to the public, it's possible that we start to see that increased incidence of Klinefelters due to earlier diagnosis purely based on genetics as opposed to clinical signs and symptoms alone. And pediatric cytogenetic analysis for various other conditions can also be an avenue where this can be explored. So I'd just like to thank Dr. Flanagan for advising on today's presentation and looking over my slides. And I would like to have any questions that the audience may have now. Thank you.